First of all, I would like to congratulate Tony Avery and co-workers with this magnificent contribution in EU experience with patient reporting. I think it's nice to know that we're not starting entirely on scratch when we go on with this project. So thank you very much for this. My presentation covers a little on Danish experience and other EU country experiences, data which I have retrieved from a survey done recently in the EU. I have included all the wording I could find in the legislation on patient reporting, but in the interest of time, I will not go through it in detail. I think the key message which we shall convey to the patients is that now we have the legal basis. Please go forward and use it. So I will just go to slide number 8. I think it is. Yes. A couple of slides on Danish experience with patient reporting. It was implemented in the national legislation in 2003, and it was promoted initially by a leaflet which was disseminated to healthcare professionals and also to pharmacists. And later in 2010, when investigations showed that there was too little awareness of the reporting scheme, by a campaign in pharmacies and also by intensified collaboration with patient organizations. The main reason why we introduced patient reporting in Denmark in 2003 was that we had a concern with a particular safety issue with an anorectic, which was suspected to be associated with thromboembolic episodes in young women, and in fact we have also had fatal cases. And this safety issue raised so much concern in the society and at the political level that it paved the way for our system. And it was clear that underreporting by healthcare professionals was a problem, and there was a strong request from consumers to become involved. Initially we used the same reporting scheme as for healthcare professionals, but we soon learned that it did not work. And it was a very large challenge to create a suitable patient reporting form. And I think it's important to stress that you should not underestimate this task. It's very, very important that you put considerable work into reaching the ideal reporting form. The vast majority of the cases initially from patients were describing adverse drug reactions, which were already mentioned in the SMPC and which were non-serious. And the male to female ratio was, as expected, 1:2. As with reports received from healthcare professionals, also the patient reporting is impacted by media attention. We see stimulated reporting by media cases described in the media. What was a surprising experience was that the social media are used by patients to disseminate information. So when a patient observes adverse drug reactions and report it to the authority, they do not keep this information to themselves. No, they go to the Facebook and create a community and a discussion forum, and this also creates some stimulated reporting. We handle consumer reports in completely the same way as we do with healthcare professional reports. Of course, we have identified some quality issues, but this is also often the case with healthcare professional reports. And we have some concern with regard to the lay language, which require interpretation, and sometimes you are not certain that you interpret the message from the patient entirely correct. We can request medical information if the patient has provided permission. We did a later analysis of the data material of the entire number of reports received from all sources in 2004 and 2006. And we analyzed the data for reporter source seriousness, system organ classes, reported and suspected drug. And the consumers reported at that point in time 11%, 45% of the reports were serious, and this was as for the healthcare professionals. And only for one system organ class, namely the system organ class neurology, we could observe significant difference between the two reporting sources. This slide shows the gradual increase in the number of reports received from the patients. The blue columns represent the healthcare professional contribution, and the red columns the reports from consumers. And as you can see, after a modest start, the number of reports are gradually increasing. Then I would like to spend some time on the main results from a survey report on patient reporting, which was done by colleagues in the Netherlands, Florence Hansel, Linda Hermark, and Kees van Grodest from Netherlands Pharmacovigilance Center Lorep and University of Groningen. It's a project in the framework of the 7th framework project, Monitoring Medicines. And the survey reports the result of a review of direct patient reporting of adverse drug reactions in 11 countries. I will only cover the 5 EU countries in this presentation. Next slide, please. It doesn't function. Thank you. The objective with this project was to try to obtain harmonized global consumer reporting, to strengthen consumer reporting of ADRs through reviewing of existing consumer reporting methods, identification of optimal methods for consumer reporting, and training in best practice in consumer reporting of medication-related problems. So according to this survey, in most member states having patient reporting schemes today, it's a governmental organization taking care of it. The exception is the Netherlands, where it's a private independent foundation, the Lorep, but this organization works closely together with the national agency. It's also typical that the organizations collect reports from healthcare professionals. The motives for introducing patient reporting was mainly 3: empowerment of the patient trend, having impact on the decision, the fact of underreporting, and then also the pragmatic way of thinking. An EU initiative was underway, so why not get some experience right away? The patient reporting schemes were launched in the EU from 2003 until 2010 in some member states following pilot projects. All 5 member states receive data electronically, and in Sweden in addition on paper, and in the UK in addition by telephone. And it's possible to write free text, and there are also mandatory fields, and E2P is used. The ADRs are coded in the metro terminology. There is performed check for duplicates. Personalized feedback to the patients is done in only 1 member state, in the Netherlands. Follow-up information can be requested in 4 member states, and in those 4 member states also permission to contact the healthcare professional can be obtained in the reporting form. Causality assessment of all individual case safety reports is done only in 1 member state, the Netherlands, but in all member states there is a classification according to serious or non-serious. So the recommendations originating from this survey are mainly the following. It's important to create awareness of the system. We have to consider how we can reach the public, how we can do better marketing of the system. We should offer electronic reporting according to international E2B standards and use universal designs of forms. It's important to perform field testing of reporting forms to ensure they are comprehensible to the public. And it's important that you have a plan for how you will handle the consumer reports once you begin to receive them. So in conclusion, EU experiences with patient reporting. Prior to the legal basis for patient reporting, as of July 2012, several EU member states have launched patient reporting schemes. The contribution from patients are gradually increasing, but awareness of the opportunity to report is low. There are some differences in the way different member states handle the patient reports, and we should maybe consider how we can establish a harmonized best practice. Electronic reporting is clearly the preferred option, and in the majority of member states, patient reports are used for signal detection. And finally, there is a need for further evaluation of patient reporting to get more insight into which kind of information is provided. Thank you very much for your attention.
Thank you, Doris. I think, do we have any questions? We could probably have time for 1 or 2 questions to Doris if you want to. Go ahead, sir.
Jean-Pierre Baes from the European Union Genetic Medicine Society. Have you any idea how much response you had in your Danish experiment with response of older patients? Because in the study of Ivry, the mean age was 57 years of the responders. So my question is, it will be very important to find a way to have a better reporting from the oldest patients who are consuming the most medicine and who are reporting the less. In all the literature, it's well known that there is agreed a very important underreporting of adverse effects in older patients.
Well, I fully agree with your concern. I do not have a figure with regard to the proportion of reports received by the elderly, from the elderly, but I could have the fear that it would be a minimum due to the electronic reporting form. But it's therefore the new legislation clearly states that member states shall provide alternative reporting means as well, not only the electronic ways of reporting, because we have to take into account that there are still many citizens who are not familiar with using the internet and so forth. So I fully agree with your concern.
Andrew?
In what number of people were you able to follow up, or did you want to follow up the reports? Because I think that there are resource limitations. I don't think any country is organized to follow up all the cases that are worth following up. How do you decide what to follow up?
Well, it's decided on a case-by-case basis. Unfortunately, I do not have the figure with regard to the proportion where we have chosen to do the follow-up, but I can assure you that it's due to some kind of prioritization. The level of seriousness, if it is brand new information, we have never heard about it, and so forth. So we have a list of criteria, and as I said, we handle the consumer reports as completely as we do with healthcare professionals. So criteria of seriousness and if it's new information and so forth.